We thought this topic is really, really important for us to learn about various lung functions and capacities, how to interpret all this in a setting, basic interpretations at least, not, if not to a specialist level. So today we have two faculty, Dr. Sunil Kumar and Dr. Anshul. Uh, Dr. Sunil is an assistant professor in pulmonary medicine at ESI Hospital, New Delhi. Dr. Anshul is also working in the same institute, and both of them are in the same department. And they have special interest in sleep medicine, interventional pulmonology. Both of them have a lot of publications in the respective fields, and they have teaching experience for around 8 years, both of them. Thank you so much, Dr. Sunil and Dr. Anshul, for helping us with this. These are a group of palliative care physicians. Most of them work in a community setting as well as in a hospital setting. So it will be very, very useful for us to understand how to interpret all this and what does it mean, how to make sense out of all these investigations and parameters. Thank you so much for being a part of this program, and thank you for agreeing to share your knowledge with us. Welcome.
I think Dr. Sunil will go first. Dr. Sunil, can you unmute from your end and speak?
Dr. Sunil, can you hear us? Sir, I think you're muted. We can't hear you.
Will take, then after he will take after that.
That will be great. By the time we can fix Dr. Sunil's.
Yeah, sure. Am I audible?
Yes, sir, you are.
Can I share my screen?
Sure, sir.
Yes.
Good evening, everyone. I'm Dr. Anshul Jain. I'm assistant professor in Department of Pulmonary Medicine at ESI PJMSR Delhi. And today we are going to discuss about the basic approach to arterial blood gas analysis, that is ABG. So why is it necessary to have knowledge of ABG? Because as you know, all the cells of the body are in the state of homeostasis and wants to be in the state of homeostasis. And any disturbance, whether in the acid form or in the base form, that is acidemia or alkalemia, could disturb this pH or could disturb this homeostasis and have adverse consequences. While living, eating, and daily day-to-day activity, we produce acid that lead to the alkalosis, and for that we have various mechanisms in the body to maintain that pH balance. Started from the chemical blood buffer, which is present already in the body. Lungs and kidney are the major organs to maintain that pH, and every cell of the body itself have a intracellular homeostatic mechanism to maintain the pH of the cell as well as of the body. These buffers, we will not go into detail of these buffers. These are basically extracellular, start from the hemoglobin, plasma protein, and PICAF systems are there. So before approaching to the ABG, that is acid blood gas analysis, arterial blood gas analysis, first of all, we must know the patient history and clinical presentation to correlate with that ABG. Like if a patient having acidemia, he would have hyperventilation as a compensatory mechanism. An alkalemia patient would have paresthesis or tetany. Followed by, we will go with the ABG, and ABG must be sent to the machine for the machine to for interpretation of the ABG. The sample should be sent in the syringe as soon as possible, and that syringe must be promptly anticoagulated before sending it to the machine. Along with urine pH, plasma and urine electrolyte concentration and lactate concentration would provide the additional information along with the ABG in the proper complete diagnosis of the patient. So start with the basic ABG. There are 4 basic parameters are there. That is pH, PCO2, bicarb, and PO2. The normal pH of the human body, basically in the arterial blood gas analysis, arterial blood gas is 7.36 to 7.44. And variation from this pH would call acidemia or alkalemia. If the pH of the arterial blood is less than 7.36, then it will call acidosis or acidemia. And if more than 7.44, then it is called alkalosis or alkalemia. The PCO2 normal range of the body is 36 to 44 in the arterial blood. And variation from this PCO2 level will be abnormal. Less than 36 would be in the favor of alkalemia, more than 44 in the favor of acidosis. The bicarb level in the human body is normal, is 22 to 26. Around 24 is average, and variation from this range would be the acidemia or alkalemia. Along with anion gap is also there the entity. We will discuss this in detail in later slides. And PO2, normal PO2 of the body is around 80, and if it's less than 60, then it is considered as abnormal. So what are the indications to have a ABG done? Basically, ABG is to assess the respiratory failure, mainly the respiratory acidosis, along with metabolic acidosis, also the component. But in ICU, the main reason to have a ABG done is for the respiratory failure patients, along with when we do the interventions like we are applying the non-invasive ventilator or the invasive ventilator to the patient and how he is responding, that we assess by the ABGs. Along with LTOT also, like long-term oxygen therapy, how much the patient have benefit from the LTOT therapy was assessed by the ABG. Weaning from the ventilators. There's a lot of weaning parameters before weaning the patient from the ventilator that has to be fulfilled, and in their parameters, ABG have an important role. Like when we going to start the weaning the patient from the ventilator or giving the spontaneous weaning trial, before it, pH must be more than 7.30. Again, to assess the acid-base disturbances, like metabolic disturbances there, which kind of metabolic disturbances there, and what are the consequences for that ABG must be done. In the diagnosis of chronic lung diseases like ILDs and obesity hypoventilation syndromes. Like if a patient having obesity hypoventilation syndrome, he would have obesity along with daytime hypercapnia that help in diagnosis of OHL. Also in pre-op patients, to evaluate the high-risk patient before surgery, ABG is must. Now, a stepwise approach for the interpretation of ABG. First of all, when you get the ABG in your hand, you have to check for the validity of the ABG, whether the ABG is valid or not, followed by the what is the primary acid-base disorder, what are the compensatory response, and use the gaps, that anion gaps, especially in the case of metabolic acidosis. So the first step in the interpretation of ABG is validity. It is checked by Henderson-Hasselbalch equation, which says hydrogen ion into bicarb by PCO2 should be equal to 24. And this hydrogen ion is calculated by the pH. In an ABG, if you get the pH of 7.40, then hydrogen ion would be 40, 80 minus 40. That is hydrogen ion calculated by 80 minus last 2 digits of the pH. And that hydrogen ion into bicarb by PCO2 must be 24. Plus minus 2 difference can be considered. If it's more than 2, then it means the ABG is not valid and had to repeat the ABG. The second thing, that is the most important slide, that what are the primary acid-base disorders in the ABG. Like in respiratory, there are 4 kinds of respiratory disorders are there: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. In the respiratory acidosis, there would be increase in PCO2. In respiratory alkalosis, there was a decrease in PCO2. In metabolic acidosis, bicarb would decrease, and in metabolic alkalosis, bicarb would increase. So when you get the ABG, after checking the validity, you have to look which is the primary disorder. If the PCO2 is increased, it means it's a respiratory acidosis. If a bicarb is decreased, it means it's a metabolic acidosis. If a decrease in the PCO2 is the primary entity, that means it is a respiratory alkalosis. If the bicarb is increased, that is, it means a metabolic alkalosis. These are the primary one. You could get one or two disorder at a time that will be discussed later. But first of all, we should know how to interpret the primary disorder. For these primary changes, there will be the compensatory changes in the ABG, and it would be in the same direction. Same direction means if there's a primary disorder of increased PCO2 is there would be compensatory increase in the bicarb. If there's a decreased PCO2 is there, bicarb would decrease. If the bicarb would decrease, like in metabolic acidosis, to compensate, patient would hyperventilate and PCO2 will fall. In metabolic alkalosis, when the bicarb is increased as a compensatory mechanism, PCO2 will also increase. So let's start with the respiratory acidosis. What are the primary causes of respiratory acidosis? Start from the lung diseases, whether it could be the COPD, ILD, ARDS could be there. In CNS depression, where the central drive is affected, like by sedatives, CNS diseases are there. Trauma could be there. Obesity hypoventilation syndrome is also having drive affected CNS depression. There are the musculoskeletal and neuromuscular disorders like kyphoscoliosis, Guillain-Barré syndrome, myasthenia, and polymyositis could lead to respiratory acidosis. Some pleural diseases like large pneumothorax and pleural effusion, where the lung compliance affected, can have a result of respiratory acidosis. So how the compensation occur? Normally, when we talk about respiratory diseases, there are two types of presentation, acute or chronic. Acute means like large pneumothorax are there or pneumonia could be there, that lead a acute presentation. And in that condition, if 10 mm increase in the PCO2 is there, for that compensatory, 1 milliequivalent per liter of bicarb would increase. Mean for 10, 1 bicarb increase as a secondary compensatory mechanism. In a chronic cases, for every 10 mm increase in PCO2, bicarb increase by 3 to 4. Means an acute one for 10 for 1, and for chronic 10 for 3 to 4 would increase. And this compensatory mechanism would take 3 to 4 days as a renal compensation. And this respiratory acidosis compensation would not lead to too much increase in the bicarb. Means if the bicarb is increased above 30, like when the patient having a PCO2, normal PCO2 range is around 40, maximum it could go up compensatory mechanism up to 70. Means 30 mm increase in the PCO2 level. That lead to maximum increase in either 3 or 9 to 12. If the bicarb increase more than 30 or 32, then we should need to look for other secondary cause of increasing bicarb, like metabolic alkalosis. The practical implication of this thing we could find in the ICU, where we get the COPD patients with cold pulmonale as a chronic mechanism. They have increase in the bicarb by 30, but sometimes it could be 40 or 50, because in respiratory ICU we generally use diuretics that lead to metabolic alkalosis. We use steroid that lead to metabolic alkalosis. So generally respiratory acidosis and metabolic alkalosis found in the combination in ICU. Now the second entity is respiratory alkalosis. The cause of the respiratory alkalosis are mainly hyperventilations, like in catastrophic CNS disorders. Intracranial hemorrhages could be there. Some drugs like progesterone could lead to hyperventilation. Pregnancy itself is a physiological mechanism lead to hyperventilation and respiratory alkalosis. Lung compliance decreases diseases like the diseases ILD, where we have increased minute ventilation and the tidal volume is less, so respiratory rate would increase and lead to hyperventilation. And finally, respiratory alkalosis. Pulmonary embolism patient would also have hyperventilation and respiratory alkalosis. Respiratory alkalosis, even in the absence of hypoxemia, and sometimes in anxiety and cirrhosis patients and sepsis patients could be found. How the respiratory alkalosis patient presents, generally because of the hyperventilation, ionized calcium decrease, that is they cause intracellular along with potassium. These kind of patient would have hypokalemia and hypocalcemia. And the clinical manifestation would be tetany, hyperreflexia, sometimes seizure could be there because of the hypokalemia and hypocalcemia. Muscle cramps would be there, lightheadedness, and perioral on extremities paresthesia would be the clinical manifestation in the patients of respiratory alkalosis. The compensatory mechanism of respiratory alkalosis would be, like as we said, it would be in the same direction, and respiratory alkalosis PCO2 will fall. As a compensatory mechanism, bicarb will fall, and bicarb will fall as like same in the respiratory acidosis. There we have 10-for-1 for acute condition and 10-for-3 to 4 for chronic condition. Here we have 10-for-2 and 10-for-5. If the PCO2 fall by 10, then bicarb will fall by 2 in the acute condition like pulmonary embolism. In chronic conditions, for every 10 mm fall in the PCO2, bicarb fall by 5. And if the bicarb has dropped more than 2 to 4, but this mechanism is not too high, means it limitation is up to 4 bicarb level. Means if the 24 is there and the bicarb is fallen by less than 20 or 18, then we should suspect some superimposed metabolic acidosis or sepsis component could be there. Now the metabolic acidosis, which is one of the most important and complex entity which we are going to discuss. Their hallmark is decrease in the bicarb, and as a compensatory mechanism, when decrease in the bicarb is there, there would be decrease in the PCO2 in the patients of metabolic acidosis. There are various mechanisms of metabolic acidosis like increased acid production, decreased renal excretion, bicarb loss by the gastrointestinal tract like diarrhea, and non-bicarb solution added to the extracellular fluid. So when we know that it's a metabolic acidosis in the ABG, where pH is less than 7.35 and bicarb is falling, then have to look for the anion gap. That is the second step in the patients of the metabolic acidosis. First, the diagnosis of metabolic acidosis is confirmed, followed by now we have to look for which kind of metabolic acidosis are there. There are two kinds of metabolic acidosis, high anion gap, normal anion gap. So we need to know what is anion gap. Anion gap, when we define, that is, it is the difference between measured cations and anions to look for the unmeasured anions. In broadly, we could say anion gap is the difference between measured cations in the extracellular fluid, that is sodium, and measured anion, that is chloride and bicarb. And the difference would be 12 is normal and the range is 10 to 14. That is the anion gap definition. It would also affected by the albumin level, and for every 2.5 milliequivalent liter for every 1 gram per deciliter, albumin is decreased from 4.0. But we will not go in detail. You just need to know that two types of metabolic acidosis are there, high anion gap and normal anion gap. And anion gap calculated by the electrolyte, sodium, chloride, and bicarb, the normal range is 12. So there are two types of anion gap metabolic acidosis. Normal anion gap metabolic acidosis examples are there's a mnemonic called HARDUP, like hyperventilation, acidosis, acids like carbonic anhydrase inhibitor, we use Addison's disease, parenteral nutritions, renal tubular acidosis. In diarrhea, we will get the normal anion gap acidosis, and urethral sigmoidostomy and ileal divergence like pancreatic fistula or drainage, we will get the metabolic acidosis, which is normal anion gap. Whereas the increased anion gap metabolic acidosis, we will get in the mud piles cat. That is methanol poisoning, uremia or renal failure, decay, paraaldehyde poisoning, iron or isoniazid intoxication, lactic acidosis, starvation, carbon monoxide poisoning, aminoglycoside poisoning, and theophylline. The best clinical implication of this is if in a patient of sepsis, you are getting the metabolic acidosis, you need to look for AKI, especially the uremia part, or the decay part, or sepsis lead to lactic acidosis that would have metabolic acidosis. Now, the compensating mechanism in the metabolic acidosis is expected PCO2. So expected PCO2 as a secondary compensating mechanism would be calculated by this formula: 1.5 into serum bicarb plus 8 plus minus 2. That is called Winter's formula. If the PCO2 calculated by this formula is lower than expected, means ideally it should compensate. And if there's a PCO2 is high or less than compensation, there must be another component should be there. Either it could be the acidosis or it could be the alkalosis. Like if the PCO2 is lower than the expected, then there must be a concomitant primary respiratory alkalosis along with metabolic acidosis. Like we have already discussed, in patient of sepsis, there's an increased lactic acid that lead to the metabolic acidosis. Along with sepsis patient, he would hyperventilate, lead to the secondary respiratory alkalosis as an additional mechanism. And if the PCO2 is higher than the expected, then there is a concomitant primary respiratory acidosis. Like in the patient of COPD, patient could have both sepsis as well as COPD acute exacerbation, would have both metabolic acidosis as well as respiratory acidosis. Now, what are the clinical manifestations of acidosis? Whether it's a respiratory or metabolic, patient, if mild acidosis would not have too much symptoms, but if the symptoms are less than, pH is less than 7.2, would have cardiovascular system effects, like it affect the myocardial contractility, lead to the decreased output, failure, hypotension, and ultimately tissue hypoxia due to the hypoperfusion and pulmonary edema. The third step in the patients of metabolic acidosis after calculating the anion gap is delta gap. That is quite complex. You just need to know the single thing, that is, it is the ratio of anion gap along with bicarb gap. And if the ratio must be 1 to 2, if it's more than 2, there must be, along with metabolic acidosis, whether it's a normal anion gap or high anion gap, there's another entity is there. For that is the delta G. And delta G more than 2, then have to look for another entity. That's it. And metabolic, now the fourth and the last one is metabolic alkalosis. Usually this entity is found in the volume contraction states, like volume loss by GI tract, kidney, skin, or another place, hypokalemia, glucocorticoids use, Bartter syndrome, or exogenous alkali ingestion. We have already told that glucocorticoids and diuretic or any other form of volume loss lead to the metabolic alkalosis. Now there are two types of metabolic alkalosis are there: chloride responsive and chloride resistant. No, in compensation, and we will discuss this chloride responsive or chloride resistant. As a compensating mechanism in the metabolic alkalosis, there would be increase in the PCO2. But PCO2 should be increased by more than 5 mmHg for every 10 milliequivalent per liter of the increase in the bicarb for the PCO2. That is metabolic alkalosis. Now, which kind of metabolic alkalosis would respond to the volume that we have to look for by the urine chloride level? That is called chloride responsive metabolic alkalosis. If the urine chloride level is low, less than 10 mm, these patients respond to the chloride, and these are the patients where the fluid loss is there by the use of because of the diuretic therapy, gastric fluid, or in the form of stool losses are there. But in the second kind of metabolic alkalosis, which is chloride resistant, urine chloride level is normal, that is less than 20, and these are the patients where we use mineralocorticoid stimulate hydrogen ion secretions, hypokalemia is there, Bartter, Cushing syndrome, or steroid abuse are there, that lead to such kind of metabolic alkalosis, which is not respond to the fluid management. that was all about the interpretation of the arterial blood gas analysis. Now we will discuss some clinical cases of metabolic acidosis, which is a quite difficult entity compared to the other entities like respiratory acidosis, alkalosis, or metabolic alkalosis. We have got one patient. He is 63-year-old, presented with a generalized malaise. His ABG was around, ABG showed pH 7.32, PCO2 was 24, bicarb was 12, sodium was 135, potassium was 5.8, and chloride was 101. So what kind of acid bed disturbance this patient has? Let's start with the beginning. First of all, we have to check whether the ABG is valid or not by the formula hydrogen ion into bicarb by PCO2 equal to 24. Here we have 7.32. We will, this 0.32 have to detect, subtract from 80, and we will get around 48. That 48 into 24 by bicarb equal to 24. That is the way of checking the ABG. Followed by, now we will look which kind of metabolic acidosis component is, which kind of component entity we are dealing with. Like pH is 7.32. It means acidosis is there. Second, we have to look for which kind of acidosis is there, PCO2 or bicarb, respiratory or metabolic. Here we have PCO2 normal, even lower than normal, less than 40. It can't be the respiratory acidosis. Then we'll look for the bicarb, which is less than 24. It means it's a metabolic acidosis, the primary entity. Now, in the primary entity, we have to look for compensation. So for that compensation, we have the formula. We have discussed that 1.5 into bicarb plus 8 plus minus 2. It means 1.5 into bicarb 12, that is around 18, plus 8 means around 20, plus 8 plus minus 2. It would come around 22. That is acceptable. Plus minus 2 is there, means there's a full compensation of PCO2 for bicarb. Now, which kind of metabolic acidosis this patient have? So we will look for the second step, that is anion gap. So this patient having anion gap sodium minus chloride plus bicarb, that is 135 minus 101 plus 12, that is around 113, and 113 when we detect from this 35, it will be around 16. Means up to 16 it's acceptable, that the normal range is 10 to 16. That is, it's a pure high anion gap metabolic acidosis is there. There's nothing else. This patient has pure anion gap metabolic acidosis are there, having creatinine of 500 ml mg per deciliter. So this patient was having that time acute renal failure. Because of that, patient was having anion gap metabolic acidosis. The second one is ABG having pH 7.11, PCO2 was 16, bicarb was 5, sodium was 133, and chloride was 118. Here you could see patient have pH 7.11, that is acidosis is there. Here the main entity is bicarb is falling and PCO2 is also lower side. It means that some metabolics are there. And this metabolic acidosis, we look for the compensation, whether the compensation is complete or not. So 1.5 into 5, that is around 7.5, plus 8, that is around 15.5, plus minus 2. Means bicarb PCO2 is 16, it's fully compensated. And now the second step is anion gap, that is 133, 118 plus 5, that is around 123, around 10 is there, which is normal. That is normal anion gap metabolic acidosis patient was having. And the patient having simple non-anion gap metabolic acidosis. The patient is 74-year-old lady, very anxious lady who presented with severe gastroenteritis. Diarrhea was there, and the diarrhea we already know that it leads to the non-anion gap metabolic acidosis. The third clinical scenario is there, that patient was having pH 6.88, that is acidosis are there, along with bicarb was 7, PCO2 was 40. That means it having metabolic acidosis are there, along with sodium the anion gap, when we talk about 118 plus 7, that is normal anion gap metabolic acidosis are there, along with patient having we have to look for the PCO2 also and the compensating mechanism. When we talk about the compensating mechanism, 7 into 1.5, that is around 10 plus 8, means ideally PCO2 must be around 20, but the PCO2 was 40. It means the patient was having additional respiratory acidosis component was there, and the patient was described in case 2 was sedated with a benzodiazepine, means that it is the same patient which was in the clinical case 2, where we having normal anion gap metabolic acidosis, and when we sedated, she started retention of the CO2, and that led to the respiratory acidosis as an additional component. Thank you. Thank you so much. That was all about the arterial blood gas analysis. Any question?
Thank you, Dr. Anshul.
Yes.
I think it's a good time to ask questions because arterial blood gas can be, there can be questions to ask. So even if you put up your case 1, share the screen. Is that how you all want to do it? Because it was my mistake that when we decided the schedule, we got good feedback from participants that we should do the basics, which is PFT and ABG, before we go to the diseases, which is the reason why we wanted, we kind of juggled the timetable and got Sunil and Anshul to do this basics. So if you want, we are happy to go case by case. And if you all have questions, you all can ask questions, or you can, let's flip it the other side. When you go to see patients, you can also ask the difficulties you see while seeing those patients. So please tell us how you all want to go about it. In the meantime, there is one question here, which is venous blood gases can be of help. Yes, so Navish is asking you, Anshul, can venous blood gases be of help if
yes,
you don't?
If we, in some cases, when we are not able to take the AVG, as you could see in the slide also, there are few differences are there with the arterial gas analysis. As you could see, the pH difference would be there. Like if the pH in the normal range for the arterial blood gas analysis is 7.36 to 7.44, but in the venous gas, there's already pH is on the lower side and PCO2 would be in the higher side. So carefully examination of the venous blood analysis would also help in the patients of could also help in the patient for interpretation. But when you talk about the PO2, when we are looking for the PO2, that is the most important part that could not be interpreted with the help of venous blood. So yes, for the pH only and for the PCO2 only the part, you could use the venous blood.
But and I want to just help to be the mediator between pulmonologist and palliative care physician, because I'm an interface and an overlap there. So the two questions, Anshul. One, where would you be okay doing a VBG? One. Yes. Two, in a palliative care setting, we don't want the patients to be uncomfortable. So ideally, we do less monitoring, less investigation, and arterial blood gas is painful. And how does it help in a palliative care setting? See, we are not going to crucially fight tooth and nail to reverse the situation. We are already, when they reach us, it's a situation where things are, most of the times, things are pretty bad and the outcome is going to be poor. So in such cases, where is VBG helpful? Because arterial blood gas can be painful for the patient when it not result what we want in palliative care setting.
Ma'am, as in a palliative care setting, in my view, probably for repeated monitoring if required for the pH or PCO2, venous gas is actually a very good entity which we could use. But when we looking for the basically PO2 and when you patient in sepsis, like in hypotension are there, and we can't rely on the pulse oximeter parameters, like basically saturation is not recordable. Their PO2, that is arterial blood gas analysis could help. But yes, when the repeated monitoring is there, we could go with the venous blood gas analysis. So
another way of looking at it to explain it is that suppose you're using NIV to make the patient's breathlessness comfortable, then to monitor venous blood for carbon dioxide is okay. Because you titrate the NIV settings in situations where you want to keep the patient comfortable with his breathlessness. although many patients complain of being uncomfortable on NIV, but if the patient is comfortable on NIV, the best way to monitor carbon dioxide level can also be a venous blood gas. If you're taking venous blood for anything else, you can therefore prick, there is a justification to prick the patient.
Definitely.
So unless there is very strict monitoring and where you want to decrease the ventilatory settings, wean the patient of ventilator, get him out of ICU, then yes, arterial blood gas is a must. But otherwise, a VBG is good enough for titrating the NIV settings of the patient. Correct?
Yes.
Okay. Next question to you is, in the last case, you can share the last case if you like. CO2 is a normal range. So should it be considered as without compensation or with respiratory acidosis? This question, I'm just going to say that when we talk of acidosis and alkalosis, it is a pH we consider. PCO2 is not the one to be considered. So when you talk of compensation, it is a pH that we need to look at.
Definitely.
So it can be anything. If it's an acute setting, pH is still not compensated. So it's acute acidosis or alkalosis. Please remember, PCO2 is not the parameter. Is that what you wanted to ask, Dr. Anita? And they want you to explain the delta gap, Anshul.
Okay, fine, ma'am. I will explain the delta gap. I thought that would be quite difficult for the people to learn. Otherwise, I will explain the delta gap. That's
yeah, if you can, that will be great. We'll try. I mean, they can at least hear you out.
Yes, ma'am, sure. So the delta gap, when we talk about the delta gap, first of all, we should know the anion gap. Anion gap, we have already discussed in detail that it is the difference between anions, which is measured cations, and anions, that is sodium minus chloride plus bicarb. Along with delta gap, it's the measured bicarb, which is available in the ABG, along with what the bicarb we have calculated. After calculation, what we are getting, that is bicarb is there, and the difference between what we calculated and what is present in the ABG is delta bicarb. That is the delta anion and delta bicarb gap is there, and the ratio is delta gap. And if this delta gap, normally this delta gap is around 1 to 2, and this provide the information that whether that bicarb what we are getting in that ABG is right or not. And if this delta gap is more than 1 to 2, it means that along with metabolic acidosis, which kind of either non-anion gap or anion gap metabolic acidosis, there's an additional component is there. For that, we use the delta. If the delta gap is greater than, if the anion gap is greater than that delta gap by at least 4, or probably we could say that 2 difference ratio is more than 2, there is a superimposed metabolic alkalosis or respiratory acidosis component would be there. And if it is less than bicarb by at least 4, or probably less than 1, there is a superimposed metabolic acidosis or respiratory alkalosis component is there. So basically, it's used for additional component in the metabolic acidosis patients. Hope everyone have understood. Ma'am, I'm not able to listen. You are mute.
I have also sent an attachment on the message to make it simplify. So you can, when you have free time, you can copy paste that description of delta gap at your own pace.
Okay.
The next question to you is, can you explain how uterosigmoidostomy can cause metabolic acidosis?
That I have to look for, ma'am.
Okay, so we will look for that. Sridevi, can you please note down that question? We'll get back to Deepak Sudhakaran. Dr. Vidya N is asking, in a resource poor setting where no access to ABG, when patient is only on oxygen, so what is the way we can monitor? Is there something that you can tell us, Anshul?
Ma'am, yes. When we talk about in resource limited setting, PO2 definitely we could use with we could monitor the PO2 with the use of pulse oximetry and
SAO, saturation.
Yes, saturation, and we could correlate that saturation with the PO2 level. Like when we talk about when the patient having 96, 97 saturation is there, PO2 is about 80%, 80 around. And when it falls to 90, then it would be around 88, 90 when saturation is there, then PO2 would be around 60. That would have a basic idea, we could get it. But when we talk about the PCO2 level and the pH, definitely we can't monitor without the use of ABG. The only thing which we could in resource limited setting is only saturation, and the saturation based on the saturation PO2. Like one example is there. Normally in patients of ARDS, we use the PO2 FiO2 ratio. Like PO2 we monitor with the help of ABG, and FiO2 with the help of the chart, like that when we increase the saturation, increase the oxygen flow rate, FiO2 would increase. But in resource limited setting, they have used a modification called Keigel's modification. They have used at the place of PO2 saturation. So saturation by FiO2 we could use, but the limit would be higher. Like when we defined the ARDS, it would be PO2 FiO2 less than 300. But in saturation FiO2 condition, the range would be 325. So yes, you could use it, but it would have less sensitivity for PO2 part. For PCO2 and bicarb, definitely we have to go with the ABG. Yes, if the ABG is not there, you could send the bicarb for in the labs, and you could get the bicarb level. And yes, it would help in some time, especially in the patient of metabolic alkalosis. If you are using diuretic, then on the basis of bicarb level, you could interpret the patient could have metabolic alkalosis component. But for as a whole diagnosis, ABG is must.
Any more questions on ABG? And I think, the more you practice blood gases, it will make a difference. And we are happy for you to, send back questions, because we'll be seeing you every Wednesday. So if there's any question, we can always ask Anshul, or one of us can try to attempt to solve it, because most of the people talking to you will be pulmonologists and they can solve that question to you. But yes, arterial blood gas should ideally be routinely done, not at home. It is a hospital procedure, because also the collection, the process, and how soon it reaches the lab, everything is important. So interpretation also changes with all that. We have been quite lucky, because when I did my MD, there was no pulse oximeter. We had to keep doing blood gas, and unless it was a big machine in the ICU or in the ward. So things have changed, but I think we should also use technology as well as investigations in the interest of the patient, not because it's available to us. And I think that is something we need to drill in the future generations, because for all of you, more and more fancy things will be available. But is it going to affect the clinical management of the patient is what we need to do. And how we can utilize these tests to improve the patient's condition is how it's not just another test to tick the box, but it should be something to be advised only if it's useful for the patient. Sheila has raised a hand. Sheila, do you want to unmute and ask, or type the question?
No, I want to ask. So, Dr. Anshul, good evening.
Good evening.
In the first slide, you had mentioned that acidemia means hyperventilation and alkalemia means paresthesia and tetany, right?
Yeah.
And then in one of the slides, you had mentioned regarding the respiratory alkalosis, where just on pregnancy or hyperventilating state, but they also have tetany. So, in respiratory alkalosis, you will have hyperventilation and tetany, or I got confused between those two, this thing.
The only thing
Am I clear with the question?
When the patient having hyperventilation, that lead to intracellular calcium in a efflux, and that lead to the hypocalcemia symptoms, kind of hypocalcemia. That would have paresthesia and tetany.
Okay, but in the first slide, you told Vali, when it's acidemia, then that's hyperventilation, and alkalemia, it's not like that.
No, not like that. It's a hyperventilation and acidemia as a compensatory mechanism. Sometimes.
Okay, so when that's acidemia, okay.
So when the acid builds up, the brain gets the message of increasing respiratory rate. So there is hyperventilation to wash out the carbon dioxide.
Yes.
Right. Thank you.
Yeah. Thank you for asking. Any other questions? Or shall we go to Sunil, because now he has restarted his computer and we can hear his voice.
I think we'll have Dr. Sunil's presentation. before.
Okay, thank you, Anshul, and thank you for accommodating to our request of advancing it to today. So appreciate that, and hope to meet you in person sometime, because Dipti has spoken a lot about you.
Yes.
Thank you.
Thank you so much.
Over to you, Sunil.
Dr. Sunil, can you unmute from your end?
Yes, ma'am, I have unmuted.
Perfect,
I am
sir. We
able
can
to
hear
hear,
you.
ma'am.
Yes, perfect.
Yes, yes.
Yes, ma'am. Yes, ma'am. Thank you.
Share the screen also now.
Yes, ma'am. Okay. Just a minute, ma'am.
Dr. Sunil, you want to share it from our end? Rajlakshmi can share it from her.
Yes, ma'am, I am sharing, ma'am. Yes, ma'am. I am sharing, ma'am.
Okay.
No, sir.
No,
No.
ma'am. Wait, wait. Good evening. Yes, ma'am. Good evening, ma'am. Good evening to all. I am Dr. Sunil Kumar Agrawal, Assistant Professor, ESI PGMSR Delhi. I want to give my presentation on spirometry. Spirometry is very useful for the diagnosis of obstructive airway disease as well as the restrictive lung disease. And treatment of the obstructive airway disease is without spirometry, like just we are treating the diabetes without blood sugar. So spirometry is gold standard and most important for the diagnosis of obstructive airway disease. There are the indications of spirometry. First, for the diagnosis of the disease, for the diagnostic evaluation of dyspnea and cough. For the diagnosis of dyspnea due to the obstructive airway disease, maybe due to asthma, and for the diagnosis of restrictive lung disease, and for prognosis of disease, for determining the severity of the obstructive airway disease, and for determining the chest wall disease, and for monitoring of the therapy in like obstructive airway disease and restrictive lung disease, as well as for disability evaluation, like in occupational exposure related occupational exposure related obstructive airway disease and restrictive airway disease for assessment of the disability, and for public health purpose, population based studies, and for pre-op pulmonary evaluation, and clue to the diagnosis of upper airway disease like upper airway obstruction and neuromuscular disease. Acceptability of graph means reproducibility. For a for the interpretation of spirometry, the curve should be appropriate and the spirometry should be done in a properly. If we have to see the volume time curve, volume on the y-axis and the time on x-axis, and patient should done the adequate effort. First, the patient should done the adequate effort. It means it has to blow out the air for at least 6 seconds, and then in around 6 seconds, the whole of the volume has been exhaled. It is around the force vital capacity, and the part of force vital capacity which is exhaled in the initial 1 second. This is the force expiratory volume in 1 second, FEV1, and maximum part of the FVC have been expelled in the 1 second in FEV1. So for proper acceptability of the curve, there is adequate effort, and exhalation time should be at least 6 seconds, and FVC, if the patient is having any inadequate effort, less effort, so FVC will be less. If patient does not exhale to the 6 seconds, then FVC will be less. And if there is some restrictive lung disease, then FVC will be reduced. And if there is patient is having obstructive airway disease, then FEV1 force expiratory volume in 1 second, it will be reduced. Then this is the above horizontal line, there is the expiratory curve, and below horizontal line, this is the inspiratory curve. Expiratory curve should be sharp peak followed by the gradual fall to the FVC. Sharp peak is due to the more exhalation in the 1 second, Most of the part of the FVC is actually in the 1 second and then gradually fall to the FVC, and this is the inspiratory. Below the horizontal line, this is the inspiratory curve. These are the normal graph. Some like in this curve, there is in expiratory part, there is frequent interruptions in the expiratory curve. It means patient is having coughing. So it is not an acceptable curve. So we should not use this for interpretation of the spirometry. Like in this curve, the patient has not exhaled to the 6 second. It only exhaled to the any 2 to 3 seconds. So inadequate efforts are there. Like in this curve, there is also patient exhaled only for 3 seconds. So inadequate effort is there. And like in this curve, there is a sharp start from the point 0. There is after some time it has been started that increase. So there is delayed start. So it should not be used for the this type of the curves, which should not be used for the interpretation of spirometry. So first we have, before interpretation of spirometry, we have to see the curve. If curve is adequate, then only we have to go for interpretation of spirometry. So these are. Hello, ma'am.
Go on, Sunil. Sorry.
Ma'am. Okay, ma'am. So these are the unacceptable graphs. They should not be used for interpretation of spirometry. Numeric interpretations of spirometry. Mainly predicted value is calculated for FE1, for FVC. Predicted value have to be calculated. Predicted value is calculated by the height, age, sex, and ethnicity. These are the reference value, and we have to compare with this predicted value. This is the FVC. This is the force vital capacity. Force vital capacity is maximum amount of the air patient can exhale. This is the force vital capacity, FVC. And FE, second is the FEV1. So mainly FVC used for the FVC is reduced if the patient is having restriction or patient is having inadequate effort, the FVC will be reduced. And second is FEV1, force expiratory volume in 1 second. So FEV1 is mainly used for obstructions. In obstructive airway disease, FEV1 will be reduced. And third is FVC percentage predicted. It means actual FVC upon predicted into 100. It have been compared with the predicted value. FE1 percentage predicted, actual FE1 upon predicted into 100. FE1 by FVC percentage. The ratio is FE1 by FVC into 100. This ratio is used mainly for the diagnosis of obstructive lung disease. Then first we have to assess the FE1 by FVC ratio for the diagnosis of obstructive lung disease. Then we have to assess the FEV1 for the severity assessment of the obstructive lung disease. And FVC which we use for the restriction. Then what is the FE1 by FVC? This is the mainly, as we have discussed earlier, volume time curve. This is the force vital capacity. In 1 second is the FE1. FE1 by FVC is only in the 1 second, the maximum part of the FVC have been exhaled. For interpretation of the spirometry data, first we have to assess the spirometric graph, then it is adequate, then we have to go for the spirometry data. We have to interpret the spirometry data for the diagnosis of disease. In spirometry data, first we have to see the FE1 by FVC ratio. If ratio is normal, then we have to see the FVC, force vital capacity. If force vital capacity is also normal, ratio is normal, and force vital capacity FVC is also normal. That means there is neither obstruction and neither restriction. If ratio is normal but force vital capacity have been reduced, it means this is the restriction. If ratio FE1 by FVC ratio has been reduced and force vital capacity FVC is normal, that means they are the obstruction. And obstruction, then for severity assessment of obstruction, we can use the FEV1. FEV1, on the basis of FEV1, we can stage the obstructive lung disease mild, moderate, severe, and very severe. If FEV1 more than 80% is a mild, 50 to 80% moderate, 30 to 50% severe, and less than 30% is very severe. And if ratio is reduced and FVC is also reduced, that means there are the obstruction plus restriction is also present. This means the mixed defect. Obstruction plus restriction is present, or severe obstruction can be there. Severe obstruction, severe air trapping can also lead to reduction of the FVC, and reduction of ratio. Then if there is obstruction, then we have to assess the bronchodilator reversibility testing. Then we have to done the repeat testing after 200 to 400 micrograms salbutamol. If there is increase in FEV1 or FVC by 12% and 200 ml from baseline. If yes, if there is increase in FEV1 or FVC by 12% and 200 ml from baseline, if there has been increase, then this is a good bronchodilator reversibility. Like in bronchial asthma, if there is no reversibility, there is poor bronchodilator reversibility, then more in the favor of chronic obstructive pulmonary disease, COPD. So interpretation of spirometry, first we have the FEV1 by FVC ratio. If there is obstruction, the ratio will be less than 70% and FEV1 predicted will be less than 80% and FVC will be normal. If there is restriction, ratio will be normal with more than 70%. FEV1, FVC will be reduced less than 80%. Due to FVC has been reduced, then FEV1 will be reduced. And if there is a mixed effect, then ratio will be less than 70% and FVC also less than 80%. And FEV1 also less than 80%. So on the basis of spirometry, we can diagnose obstructive airway disease or restrictive lung disease or either mixed disease. There are the limitations of the spirometric parameters. If we use the FEV1 by FVC, there is normal age-related decline in FEV1 by FVC ratio. So normal elderly patients without airway obstruction may have ratio below 70 to 80%. False normalization of FEV1 by FVC may occur in moderate to severe airway obstruction, which is caused by marked decrease in FVC due to air trapping. So in two things, age-related decline in elderly patient ratio may be less and false normalization can be there. And FVC dependent on the patient. So reduced forced vital capacity is only suggest a restrictive abnormality, either may suggest the patient have inadequate effort. And reduction in FVC may also occur due to the air trapping in moderate to severe airway obstruction. Here's the exercise with, for the interpretation of PFT. This is exercise number 1. A 29-year male, non-smoker, atopic, history of paroxysmal dyspnea since childhood, recurrent severe exacerbation since 2 to 3 months. On investigation, hemoglobin 13.2, counts 7700, neutrophil 53, eosinophil was raised 25%, AEC absolute eosinophil count was 3080, and total IG is 3000. Means the history goes in favor of patient of bronchial asthma, and bilateral diffuse bronchitis is present. And chest X-ray suggests to slight bilateral hyperinflation, rest otherwise normal bilateral lung fills. On PFT, first we have to see the FEV1 by FVC ratio. If ratio is here is the pre-bronchodilator 63%, post-bronchodilator 65%. We have to see the post-bronchodilator FEV1 by FVC ratio. It is 65%. That means this is the obstruction. Then we have to see the FVC. FVC is 79%. Is almost normal. Then we have to see the FEV1. FEV1 is also reduced. This is the 61%. So patient is having obstructive abnormality. Then for reversibility, we are saying the pre and the post bronchodilator changes in FEV1. So FEV1 pre bronchodilator 2.01, 2.07, and post bronchodilator 2.32. That means it is 250 ml increase and 15% increase of the baseline. So it is 15% and 250 ml increase in FEV1 after bronchodilator. That means the good bronchodilator reversibility. So the interpretation of this parameter is obstructive abnormality with good bronchodilator reversibility. That means the patient is having the bronchial asthma. Next, exercise number 2. A 50-year male, a chronic smoker, 1 bundle BD per day for 20 years, the 20 pack year, a 50-year male chronic smoker, and having the history of cough with breathlessness since 4 years, and saturation 98%, bilateral bronchi was present on examination, routine biochemical and the hematological investigations are normal, and chest and history of bilateral hyperinflation, lung fill are present, and tubular heart are present. On spirometry, first we have to see the ratio. Ratio is post-bronchodilator FEV1 by FVC ratio is 54%. That means the obstruction is present. And FVC is also reduced 75%. Slight reduction of FVC 75%. And FEV1 is also reduced to the 52%. So patient is having either mixed obstruction may be there, obstruction plus restriction may be there, either severe obstructive airway disease may be there. Due to severe obstruction, FVC may be reduced, severe air trapping, due to severe air trapping. And we assess the bronchodilator reversibility 1.15 to 1.22. It means plus 3%. Only 3%. This is the note. This is a poor bronchodilator reversibility. So the final interpretation may be due to the other clinical findings, and final interpretation may be due to the chronic obstructive pulmonary disease or associated with some restriction also, because FPC is also slight reduced. And for staging of, if there is COPD, for the staging of any chronic obstructive pulmonary disease, we will assess the severity assessment by FEV1. Post bronchodilator FEV1 is 52%. It means this is the stage 2, means moderate obstructive airway disease. Next, exercise number 3, 40-year male, chronic smoker, 20 BD per day for 20 years, driver by occupation, cough, severe, paroxysmal dyspnea on exertion since last 6 months, atopic, asthma in mother is also present, IG is 400, routine was normal and chest X-ray was normal. A young male chronic smoker, 20 pack year history and 6 month duration history, paroxysmal symptoms are present, and atopic and family history also positive, IG is positive, IG is 400 and routine was normal and chest X-ray was normal. Spirometry was done in November 2014, which was suggestive of ratio is 68%. That means going in the favor of obstruction. FVC is 90% is normal, and this means the and FEV1 is 72%. Slight reduction of FEV1 is present. So this is the obstructive abnormality with 1.93 to 2.28 FEV1 post bronchodilator plus 18%. This patient is having good bronchodilator reversibility with obstructive abnormality. This patient also having the history of chronic smoker. After 6 months around, in May 15, his FEV1 is increased from 2.28 to 2.50, plus 6% changes in FEV1 from baseline, and ratio is also increased 71%. So spirometry is also useful for assessing the monitoring of the patient for on treatment. This patient is was on treatment, and monitoring of the treatment, monitoring of therapy, which can be used by the use of spirometry. Next exercise is 21-year female, non-addict housewife, presented with high-grade fever, hemoptysis, and sputum was positive. Initially diagnosed was sputum positive pulmonary tuberculosis, treated with ATT, and after ATT, X-ray become normal. Initially, access suggestive of right hilar prominence, right upper lobe infiltrate, and left upper lobe infiltrate were also present. And before ATT, CT chest was done, which was suggestive of bilateral lung filled centrilobular nodules are also present, and few of them suggestive of tree in bud appearances are present. And after ATT, these nodules were also disappear, but there was some area of low attenuation and some area of normal attenuation. This is the mosaic attenuation pattern. In low attenuated area, there is decrease in the vessel size and decrease in the lucency is present. So these are the low attenuated area. This is a bilateral mosaic attenuation was present. So after treatment, after ATT, that means that patient may develop some obliterative obstructive lung disease in the form of obliterative bronchiolitis may be there. Post-infectious obliterative bronchiolitis may be there. On spirometry, ratio FEV1 by FVC was 65%. That means there is an obstruction was present, and FVC was also reduced 48%, and FEV1 was also reduced 35%. So patient is having mixed obstruction plus restrictive lung disease, and FEV1 1.13, 130 ml plus 13%. Mid expiratory flow rate MEF 50%. Mid expiratory flow rate is also 4.82 predicted, is also reduced. So it may be due to obliterative bronchiolitis, and patient is having mixed obstructive plus restrictive lung disease. Next exercise, 68-year male, non-smoker, no occupational exposure, dyspnea on exertion which is progressive, MRC grade 3, dry cough since 1 year, on examination clubbing grade 3 was present, saturation pre-exercise 94%, post-exercise 90%, post-exercise desaturation was present. On respiratory system examination, bilateral bibacillar fine crabs are present. chest is suggestive of bilateral chest is suggestive of bilateral mid to lower lung zone reticular shadows as present. Bilateral lower zone reticular shadows as present. On spirometry ratio, FE1 by FPC ratio was 81%, that was normal. Then we have to see the FVC, it was 68%. Ratio is normal, FVC has been reduced, that means it's a restriction. And FE1 was 72%, it's slightly reduced due to FVC has been reduced. So this is the spirometry of restriction, restrictive lung disease. After before treatment, FVC was 68%, and after treatment, FVC was improved to 79% due to the improvement in the underlying lung disease. And FE1 also increased to 72 to 77%, and ratio was 81% to 75% because FVC has been improved. So spirometry is useful for follow-up of the patient on treatment, for the prognosis of the disease, for monitoring the treatment. Next exercise is 70-year male, chronic smoker, 1 bundle per day, 40 years, 40 pack years. Symptomatic since 3 years, with cough and dyspnea, MRC grade 3, 3-year history, and clubbing grade 3, pre and post exercise saturation, pre-exercise 94%, post-exercise 90%. And bronchi was present, and chest and suggestive of bilateral lung field infiltrative changes are present, mostly reticular and mostly reticular nodular shadows are present, bilateral lung field. PFT was done.
Can I interrupt you and let the participants interpret this for us as a exercise for them as one PFT, and then
Yes,
you can
ma'am.
give your expert comments. Is
Ji,
that
ji.
okay?
Yes,
Yeah.
yes, ma'am.
Thank you,
Okay.
Sunil. Anybody want to volunteer, send a chat message? Just follow the simple things. I know whenever people look at a PFT report, all those multiple parameters zap you. Just highlight first the FEV1 by FEC ratio, then the
Yes.
FEC, and then the FEV1. If you manage to do these three things, you have cracked the code more than 50% of times. So please remember that in obstructive lung diseases, which is the airway diseases, it is the flow rates which is affected. So that's why we do FEV1 and FEV1 by FEC. In restrictive lung diseases, it is the volume and capacity that is affected. So FEC will be decreased, and therefore we have to focus on volumes and capacities in interstitial or parenchymal diseases, and in restrictive diseases, in obstructive, it is the flow rates. So anybody wants to volunteer and interpret this particular PFT, please go ahead. Yes, it might be a bit complicated, but just follow the steps. FEV1 by FEC ratio, next you see the FEC, and next you see the FEV1. In that order, if you remember, you have cracked the code. Anybody wants to volunteer?
I'll try, ma'am.
Absolutely.
So the FE1 by FEC is normal because it's above 70.
Above?
FE1 by FEC is
82%.
above 82%. So it's normal.
Yes.
It's normal.
So the next
And then we
parameter
see the
is?
FEC, next FEC.
Yes.
So the FEC is less. The FEC is less means it comes to a restrictive lung disease.
Okay. Next.
Exactly. And then we see the FEV1%. I mean, so FE1 also is, okay, I got confused over here. So FE1 by the ratio normal and the FEC is less, so it comes to restrictive lung disease. But again, FEV1 also is less, so it comes to a mixed this thing.
Sunil, you want to interpret that for them?
Yes, ma'am. Actually, patient is having FE1 by FEC ratio is FE1 by FEC ratio is 82%. That ratio is normal, but FEC is reduced. It means 52%, and FE1 is also reduced. There is 54% or 56%. So either it is restrictive lung disease, either it may be due to FE1 has been reduced also. So false normalization of ratio can be there.
So I would just like to remind all of you that we never interpret PFT without a history. You
Yes.
have to have a history. So if you go back to the history, Sunil,
Yes, ma'am.
the previous slide, this is a chronic smoker, which
Okay.
one bundle for 40 years, which is 40 BD pack years. He has symptoms since 3 years, and he also has the exercise desaturation. So what does this mean? This means it's an elderly gentleman, the chronic smoker. So most likely it is airway disease due to smoking. Now, why is the FVC reduced is the most important question. And the reason what Sunil is trying to explain is when you have a patient of severe COPD, what happens is as there is so much air trapping. See what
Yes.
happens in emphysema. There is when the patient inhales, the amount of air expired is less because the lung elasticity is lost in COPD. And because inspiration is an active process, expiration is a passive process. So expiration happens because of lung recoil, and the lung recoil is lost in emphysema. The lung elasticity is lost in emphysema. So every time the patient inhales, he does not breathe out what he should be in a normal lung. So because of this, constantly, this patient has what we call as air trapping. That's why in a COPD patient, you see hyperinflated chest because there's so much of air trapping. And because of the air trapping, the patient is not able to take in the next breath fully. And that is the reason which contributes. So if you see the ratio, why is it normal? Sunil, if you can put it the next slide. FeV1 by FEC. So the denominator is so low that the ratio becomes high. So
Yes.
therefore, this is severe COPD. So please remember, when you see a PFT, you must have the full history. Because if you know 70-year-old chronic smoker, then yes, it has to be airway disease. But FVC is normal. And why is the FVC normal? The ratio is normal. The ratio is normal because the FVC is so low because of the air trapping that the ratio looks normal. Am I clear?
Yeah.
Everybody has understood?
Yes.
It is not easy to interpret this, but please remember, never interpret a PFT without history. So for example, suppose you have an asthmatic with a pleural effusion. That asthmatic will have obstructive airway disease like features, but because of the pleural effusion, will also have a restrictive feature. So without the history, you cannot make the conclusion. So you always need to be very clear, because the patient has pleural effusion, it is restrictive, and that's why this low FEC is probably there. Got it? Sheila, you want to ask something?
Yeah, ma'am. Dr. Sunil, how do you calculate? You are doing the pre and post bronchodilate test. You're giving the 250 ml, and how do you calculate from these values? Like 1.55, 1.60 is given, and you have calculated the percentage change as 12%,
Yes,
or
yes.
the 250
Actually,
ml 12%. How do you calculate?
Yeah, please
these
explain.
are the FE1 is, these are the usually, जैसे the FE1 of this patient is 1.55, and they are given the FE1 percentage predicted. That means FE1 of this patient upon FE1 predicted is the 2.86. मतलब 1.55 upon 2.86 into 100. That will comes to 54%. Like FVC of this patient is 1.88. So 1.88 upon it from predicted, FVC predicted is 3.68. Then it will be FVC percentage predicted 51%. So we have to calculate, this is the patient value and this is the predicted. So we have to calculate it from predicted, percentage from predicted.
And the change one, how do you do that?
Yes,
You have
yes,
given
changes.
the
Yes, I am
ml,
telling.
ml. Yeah.
Changes in previous slide, I will tell you. Yes. If yes, like in this slide, FE1 pre-bronchodilated 2.07 and post-bronchodilated 2.32. So we have to show the difference between post-bronchodilator minus pre-bronchodilator. 2.32 minus 2.07 is 0.25. 0.25 liter, it means 250 ml. And 250 ml percentage from the baseline. It have been kitna, what percentage have been improved from the baseline. So it baseline 15% have been improved. We have to calculate the difference between pre and post bronchodilator and percentage improvement from the baseline. So we have to compare with the baseline. This is the baseline It is the pre-bronchodilator, is the baseline, and is the post-bronchodilator.
Is that clear, Sheila?
Yeah, ma'am, it's clear.
You
ma'am.
understood it's pre minus post upon pre into 100.
Yeah, ma'am, I got it.
Post minus
I got it.
pre upon pre
Yes,
into 100.
yes, ma'am.
How you calculate any change?
Yes.
Yeah, got it. Thank you.
And we actually, there are another important thing clinically in this bronchodilator change is we think anything more than 200 ml and 15% is significant bronchodilator reversibility. But for that particular patient, even 100 and 150 ml is a good bronchodilator reversibility. But for the patient, even 100, 150 ml is a significant reversibility. You understand? So sometimes clinically, the patient says he feels much better with the bronchodilator, but it might not show in values. At that time, you should report it as significant for the patient. It might be only 100 ml, but for that patient, it makes a difference. So it's important to notify any improvement in bronchodilator because it is treatment directed. Okay, some other concept has come. FVC normal value, how the predicted value is obtained. Good question. So Sunil, you want to answer that?
Yes, ma'am. This is the FVC. These are the FVC.
So basically, how the predicted values are obtained. So what is normal?
Yes,
so,
yes, ma'am.
So tell them that. Yeah.
जी ma'am. Usually, जो predicted value are obtained usually based on the reference values. This is based on the age, height, sex, and ethnicity. These are the reference value, and on the basis of this value, they are the predicted value obtained. And with this value, we have to compare the patient value. Means that observe of the patient value, which will be compared with the predicted values.
So another thing here that you need to remember is that forced vital capacity, whenever you have seen a patient doing PFT, I don't know how many have you, if the patient has understood the procedure well, and if the technician is a very good technician, then you actually, it's a patient dependent effort. So the patient, if he's understood well, he will do, or he will do. That will also make a difference in the forced vital capacity, which is why we take the ratio of FEV1 as by FVC as the most sensitive, because you and me cannot control the amount of volume of air expired in the first second of expiration. It is a completely involuntary act which depends on the status of your airways, lung recoil, and the elasticity. So FVC is patient dependent, and therefore we consider the ratio, which is patient independent, because patient is not able to control the FEV1. So that is why the logistics of seeing those particular parameters in that order is important. But of all the parameters, you need to see the 3 so that you can conclude with the history, whether it's obstructive, restrictive, or mixed, or whether it's a very advanced case of obstructive lung disease where FVC is so less that the ratio looks better, which is called as false normalization. Okay, continue, Sunil. Sorry, I interrupted you so that we could have this discussion with the cases.
We were on this slide, exercise number 6. We have completed this. So there is a false normalization of FEV1 by FVC ratio. There is severe obstructive airway disease there. Next, by using flow volume loop, these are the volume time curve. We have, by the use of volume time curve, we can assess obstruction, restriction, or mixed disorder. By using flow volume loop, we can assess the upper airway obstructions. So this slide is based on this. Next, exercise number 8. A 63-year female, non-addict, housewife, admitted with acute exacerbation of asthma. For such hospitalization in 1 year, requiring intubation and ventilation, difficulty in swallowing saliva, and noisy breathing at night. Maybe query stridor, maybe query bronchi on examination. So we are suspecting upper airway obstruction in this patient mainly based on the history, because 63-year female, non-addict, housewife, patient is recurrent admission with acute exacerbation of asthma. For such hospitalization, 1 year, requiring intubation and ventilation. There is difficulty in swallowing the saliva, noisy breathing at night, maybe stridor. So we are suspecting there may be some upper airway obstruction can be there. For upper airway obstruction, mainly flow volume loop are useful. They are the flow volume loop. They are the expiratory curve and these are the inspiratory curve. So FEF, forced expiratory flow in 50% upon FIF 50% have been calculated in this. If FEF 50% of FIF 50%, usually this ratio is between 0.3 to 1. If its ratio is less than, in this spirometry, there is expiratory curve is normal, but inspiratory curve is flattened. So FEF 50%, FNF 50%, FIF 50% is reduced. So it will increase from more than 1 into the 1.64. That means there is an inspiratory flattening, and inspiratory flattening is present in extrathoracic airway obstruction mainly. Is the variable extrathoracic upper airway obstruction present? What does the flow volume loop show? Mainly due to the adductor palsy in this patient. If FEF 50% upon FIF 50% ratio, if less than 0.3, that means expiratory curve flattening will be there, and expiratory curve flattening will be present in variable intrathoracic airway obstruction. If both curve will be flattened, expiratory curve and inspiratory curve will be flattened, that means there is a fixed obstruction. That means expiratory and inspiratory curve both will be flattened. Then ratio will be 1 in this situation. So there may be the three situations: there are fixed obstruction, and there may be the variable obstruction. Variable obstruction may be variable extrathoracic, variable intrathoracic upper airway obstruction. Like next exercise is like this: a patient of esophageal tumor, a dysphagia, having the history of dysphagia 3 to 4 months, history of stridor since 20 days, was admitted in emergency due to severe breathlessness, not getting relieved with nebulization. Patient is having stridor and chest X-ray is normal. So by history that suggestive of patient is having some airway obstruction. Then we do the flow volume loop. Spirometry with the flow volume loop. There is expiratory flattening is present in this flow volume loop, and inspiratory curve will be same. So what does the flow volume loop show? And variable extrathoracic, variable intrathoracic, and fixed upper airway obstruction. So in this curve there is expiratory flattening will be there, and inspiratory curve will be same. So expiratory flattening will be there. That means there is a variable intrathoracic airway obstruction. So there is a variable intrathoracic upper airway obstruction will be there. So finally, spirometry is not only helpful in the diagnosis of the disease, but also in follow-up of disease. It is important to train the technician properly for proper reporting of the spirometry. There are the three essential components in reading the spirometry. First, we have to see the FE1 by FEC ratio. This is the cardinal for the diagnosis of obstructive airway disease. Second, we have to see the FE1. FE1 percentage is indicative of the degree of airflow limitation. And third is FVC. FVC is usefully determining the degree of restriction. However, it is low, even patient does not perform the spirometry well, inadequate effort, or there is severe obstruction. FVC may be low. It is extremely important to correlate spirometry clinically. Clinical plus spirometric parameter interpretations. The follow-up of patients with spirometry is extremely useful in chronic lung disease and upper airway obstruction, as well intrathoracic as well as extrathoracic. Then we have to do the flow volume loop as a screening modality for the assessment of upper airway obstruction.
So Sunil, before you go and stop screen share, can you go to the flow volume loop? I'll just try and explain what I want to understand from them, explain to them. So flow volume loop is for upper airway obstructions mainly. Yes. And the spirometry is done for large airways, which is large bronchi as well as small airway disease. Okay. So what you need to understand is this patient is asked to take a deep breath. So the lower loop is the inspiratory loop. So the patient actually takes a deep breath from this point to the and the above graph is the expiratory. So the base of the graph is the total lung capacity, because the patient will breathe from forced vital capacity to total lung capacity. So the base of the graph. So please remember, a flow volume loop is mainly for upper airway obstruction. And what is upper airway? Up to the bronchus is upper airway. Therefore, the upper airway is divided into extrathoracic and intrathoracic. Extrathoracic being everything like tracheal stenosis, your trauma, tumors, whichever is upper airway, and extrathoracic. Intrathoracic is everything below the inside the lung, but above the carina. where it divides into right and left bronchus. So please remember, it's very easy. When you have an extrathoracic obstruction, it is the inspiration loop which is affected, because the atmospheric pressure is what is acting on the extrathoracic part. So the inspiration is going to be compromised. But in the intrathoracic upper airway obstruction, it is the expiration that is obstructed, because it is the recoil of the lung and therefore the negative pleural pressure that causes the expiratory loop to be compromised. So just remember that. And the beauty is in seeing the shape of the loop. If you see the shape of the loop, normal flow volume loop is a parabola. The inspiration and the expiration is a parabola. But if the inspiratory loop is flattened, you know it's an extrathoracic upper airway. If the expiratory loop is flattened, it's an intrathoracic upper airway obstruction. So flow volume loop is mainly for upper airway. Upper airway is what starts from the back of the nose to the carina, and you have intra and extrathoracic parts. Any questions? Am I clear? Sunil, you want to add anything?
Yes, ma'am.
You can stop sharing if it's okay, and then we can take some questions. But I don't want to delay everybody's dinner on the middle of the week. Thank you, Sunil.
Yes, yes.
Yeah. Any questions? I know everybody must be getting late for a dinner.
If there are any questions, we can take up, or you can, as Dr. Rajan told, we can convey that to the faculty and get back to you. Anyway, Dr. Rajan is going to be there for the session. So if you have anything to clarify, please write it down, write to us.
Thank you, ma'am.
Send to us.
Thank you, ma'am.
I didn't want to stop the discussion because it's one-time learning. We have been waiting for all these sessions. So sorry for exceeding time. That's why I told if anyone is feeling it's getting late, you're free to leave by 8:15. But
there's one question, sorry, Sridevi. In chest physiotherapy, they do incentive spirometry. What is incentive and what's the spirometry aspect in it? Either of you can take it, and if there's anything left, I can add. So I'll start. Sunil, you can add if you like.
Yes,
so
ma'am.
incentive spirometry, Dr. Deepak, incentive means basically you want the patient to do more and more. So if you have seen those 3 balls, the patient is actually told to keep one ball afloat, second ball afloat, and third ball afloat. Then you can actually increase the resistance. So it's basically like doing exercise to the arms. You keep increasing the weight to make your muscles stronger. So incentive is the incentive you give to the patient that he can breathe better and better by using different resistance and keeping all 1 ball, 2 ball, or all 3 balls afloat. And it is actually a misnomer to call it spirometry. It is only because it's a breathing exercise and it's a breathing gymnastic technique that it is called spirometry. But otherwise, it's simple incentive exercise for the patient, which improves, basically giving increased graded exercise. But it should not be used. Very often we see it bedside in all patients. You should use it carefully, because patients with things like cysts and bronchiectasis should not be blowing so hard, because then they will get a pneumothorax. So please select exercises properly. It's not a blanket chest physiotherapy for all. Can we send difficult ABG in the group for interview? Yes, please. If it's difficult for you, it will be difficult for me, but we will definitely try and solve. You can mention some palliative care pulmonary conditions in which incentive spirometry may help our patients. So it is important to realize that if you have an early referral of palliative care along with patients with advanced COPD, interstitial lung disease, that's when you can actually do active pulmonary rehabilitation and chest physiotherapy. In COPD conditions, you can use incentive spirometry. Ideally, in interstitial lung disease patients, it is not going to help much because they have a restrictive disease. The airways are fine. The incentive spirometry helps the airway health of the patient. So in airway conditions, you can use incentive spirometry. Especially if your patient is not able to go to do pulmonary rehab, he can do this by simple walking and simple upper limb exercises, stretches at home to improve the quality of his airway opening. And that's what we want, right? We want the patients to expire full so that they can take the next breath full. The problem with our patients is they're not able to expire because of the anatomical distortion of the lung due to COPD.
And I think that will be covered a little bit in the pulmonary rehab session in the towards
Yeah,
the
it
end.
will be covered in more detail. Yeah. And anyway, I think we'll also have one buffer session on COPD asthma. Now on the knowledge of PFT and ABG, maybe things will start looking a little more clear for you in the aspect of interpreting COPD and asthma and differentiating them.
I think there are no more questions in the chat. You can still write to us if you want to get more information from the experts. Thank you so much, Dr. Sunil, Dr. Anshul, and Dr. Raj for being with us and making things clear for all the participants. And thank you, participants, for the questions. Like making use of the opportunities, the intention behind all this session. And thank you so much for asking your questions and being